Good morning, everybody. Thank you for the kind introduction. And again, it's my privilege to be here to speak to everyone about this topic. So the topic given to me is about the advances in abdominal radiology, and it is not an easy topic to talk about because the scope is very broad. And it is something that truly it covers many topics in abdominal radiology. But nonetheless, I will try to give a brief introduction into what is up and coming within this specialty. So to start off with, solid organ cancers continue to rise in prevalence across the world, and abdominal cancers make up the majority of cancer deaths regardless of gender. And this is highly intertwined with our specialty because abdominal cancers still make up the majority of worldwide cancers. Of particular relevance to our practice in Asia is HCC, where it continues to be a prevalent malignancy in our part of the world. A great example of how abdominal radiology has evolved is the example of prostate MRI. Advances in practice does not have to equate to greater complexity. Multiparametric MRI of the prostate has evolved in the past few years to become more practical and user-friendly, resulting in its widespread adoption across the country, across the world. When I started my training in residency, multiparametric MRI was used for staging to assess for any local invasion and any evidence of extra prostatic extension. However, it is now the standard for diagnosis of prostate cancer, and it also enables targeted biopsies. This results in higher sensitivity and specificity for detecting clinically significant disease. Despite the high cost of MRI, it has still emerged to be a cost-effective method as a first-line diagnostic modality. And this example that I've shown over here, you can see that this is an example of a prostate MRI where after the radiologist has detected what appears to be at least a Pirates 5 kind of mass in the left lobe of the transition zone, we go on to contour this mass using software so that we can give a representation, a 3D representation, and this is then fused with an ultrasound images, which enables the urologist to target the mass better. Another mainstay of abdominal imaging in our current practice is the use of EOB MRI. The high contrast to noise ratio enables better visualization of nodules within the liver. For example, the case on the top row shows how the hepatobiliary phase detected a small subcapsular metastases in segment 4. And in the case at the bottom, it shows how EOB or EOVIS with higher liver uptake compared to other hepatobiliary agents such as multi-hunts reliably shows a HCC nodule as hyper intense in severe HCC, in severe cirrhosis, sorry. We exploit this ability of EOB to reflect OATP receptor expression and function. And using that, we can now reliably detect high-grade dysplastic nodules as well as early HCC before they transform into progressed hypervascular HCCs. And this is an example on the right-hand side where we see that on the top row, we see a very sub-centimeter hypovascular nodule in segment 8 of the liver. Segment 8 subcapsular area of the liver. On the arterial phase, it doesn't show arterial phase hyperenhancement, but it does show a hypointensity in the hepatobiliary phase. And 6 months later, this nodule progressed, it has increased in size, and has now shown arterial phase hyperenhancement. And on the hepatobiliary phase, it still demonstrates a hypointensity. And this is an example as to how EOB helps us to detect early HCCs and it guides us in monitoring and also eventual treatment. In recent times, we have also furthered our understanding of HCC with even more understanding of more complex histopathology subtypes. What is interesting is that there are some underlying histopathologic features that explain MRI phenotypes. For example, in serous type of HCC, we see progressive enhancement rather than the washout appearance that we normally see in not otherwise specified HCC. Extending our understanding of histopathology to imaging features allow the characterization of some variants according to prognosis. Beta-catenin mutated subtypes of HCC is characterized by heterogeneous uptake of hepatobiliary contrast agent, which distincts this from other subtypes of HCC, which lose OATP receptor expression. These are shown to have better prognosis, but interestingly, they respond less well to immune checkpoint inhibitors. We also know that certain MRI phenotypic features of HCC can portend either better or worse prognosis. And a good example of this would be the LIRADS-M observations that we see on MRI livers. So this study has shown that patients with cirrhosis who underwent surgical resection of HCC, LRM category at preoperative imaging is predictive of shorter overall survival and recurrent-free survival relative to other LIRADS-4 or LIRADS-5 observations. This is another example which showed imaging features such as tumor size, the presence of satellite nodules, presence of irregular rim-like hyperenhancement of the tumor, peritumoral parenchymal enhancement, or peritumoral hypointensity observed on the hepatobiliary phase. These are all independent imaging features which predicts a worse prognosis in patients with HCC. As we deepen our understanding of the link between imaging features and tumor biology, we will start to see the shift of radiology diagnostic guidelines from diagnosis to prognosis. A good example that we have highlighted is that I will highlight is a recent Asia-Pacific multidisciplinary team meeting, which showed the association between peritumoral enhancement and washout with MVI or microvascular invasion, which is a poor prognostic factor for patients with HCC. We move on to radiomics. Radiomics suggests that we are getting closer towards extracting more information that's visible to the human eye. And this is a reflection of the histology, biological activity, function, etc. And there's great potential for prognostication and outcomes prediction. However, issues such as heterogeneous data samples and difficulty in reproducing results still is a factor that hinders radiomics in routine clinical practice. At the current moment, the emerging trends in abdominal radiology are really heavily driven by industry, and there are multiple new areas that abdominal radiology can really delve into. So one of the next things will really be about artificial intelligence. So deep learning could replace the laborious segmentation and calculations that some of the radiologists or trainees have to do. And you can extract much more from an image than what the radiologist has the bandwidth to process. As abdominal radiologists, we can derive more information, not just about the visceral organs, but the overall muscle and metabolic health of our patients. And this is an example of one of the projects done by one of my colleagues back in Tan Tock Seng, where the segmentation of body and visceral fat could be used to predict sarcopenia assessment on MRI. And the assessment of sarcopenia also is a predictor of cardiometabolic risk. Deep learning can also augment radiology workflows to improve patient care. The adoption of many clinical AI models has been somewhat slow, and radiology practices are still trying to show its value at the current moment. However, I think the team in DTSH believes that the lower hanging fruit that AI can do is really to augment our radiology workflows. And this would mean accelerated scanning times with higher signal to noise ratio. This would help in lowering, in things like lowering radiation dose on CT and field strength, reduce the overall scan time, especially with MRI studies. And as a result, it can increase patient throughput. Other examples would be using large language models for data synthesis, and this can help to do quality assurance of radiology reports. Can also help, it can potentially help to prioritize imaging scans, and also possibly summarize indication for referrals. However, despite all the talk about artificial intelligence, it should still not distract us from the other continually advancing domains in abdominal radiology. Example would be photon counting CT, which has been talked about in earlier lectures. At the current moment, photon counting CT is starting to take off in Singapore, with at least a few hospitals starting to have plans to purchase photon counting CTs for their departments. The advantage of a PCCT or photon counting CT is that there are differences within the physics of how the image is generated. Routine CT studies uses a scintillator to generate visible light when the incident X-ray photon hits them, and the light is recorded by a photodiode. However, photon counting CT scans use a semiconductor to generate positive and negative charges, with the negative charges going to anodes in the detector, which generate electronic signals. There are several clinical applications and advantages with using photon CT, which is summarized in this table. Examples will include higher spatial resolution, improved iodine signal while using less volume of iodine-based contrast, radiation dose optimization, artifact reduction, as well as the ability to do multi-energy imaging. Other advances that are fairly new, and also not new, but they are taking greater precedence in at least within the departments in Singapore, with things like qualitative liver imaging. So for a good example would be fibrosis imaging using MR elastography. It has its advantages over other forms of non-invasive liver fibrosis imaging, such as fibroscan or ultrasound shear wave elastography, in the sense that it covers a greater area of the liver, and is also studies have also shown that it's more accurate compared, more sensitive to the earlier stages of fibrosis compared to fibroscan. Other forms of qualitative liver imaging would be using MRI to quantify the amount of fat and iron within the liver. And I believe later my colleague, Dr. Chang Won, will be giving a more detailed lecture on fat and iron quantification within the liver. Rather than just analyzing images, abdominal radiologists can also guide preoperative decisions in a more tangible way by using 3D printing. In this example that I've shown over here, we have a rather irregular looking mass in the upper pole of the right kidney. The urologist wanted a more clearer visualization of the vessels, as well as the collecting system involvement by the tumor. As part of this patient's surgical planning, we opted to help the urologist by doing a 3D printout of the tumor with the kidney, as well as the adjacent vessels. And this was able to help the surgeon visualize the RCC, which is highlighted in green. And that helped to determine whether or not a radical nephrectomy or whether a simple partial nephrectomy was required for this patient. CT volumetry is another area that in my institution is routinely used for preoperative planning. Hepatectomy remains one of the key treatment options for liver malignancies, and post-hepatectomy liver failure is a potential complication. CT volumetry calculates the volume of the remnant liver segments based on the CT images required, and it helps the liver surgeon know the remnant liver volume, and this can be used in conjunction with other parameters such as liver function tests and ICG to help determine whether the patient is a suitable candidate for major liver resection. Take the example of a patient who had a large mass in the right lobe of the liver. The surgeons wanted to plan for a right hepatectomy, but they were concerned about whether there was enough liver volume left behind for the patient. As such, he was referred for CT volumetry, and our radiologists contoured the area of the liver with a line in the middle which shows the potential resection plane. And we generated a 3D image for the surgeon in order to visualize the vessels as well as its relation to the tumor. In another example, we have another patient with a mass in the right lobe of the liver. And this time, CT volumetry was performed, which demonstrated that the remnant left lobe that was going to be left behind was too small relative to the patient's body weight. As such, in order to increase the volume of the left lobe of the liver, the surgeons as well as the interventional radiologists worked together to perform portal vein embolization on the right side. This helped to divert more blood flow towards the left side of the liver to encourage hyperplasia. And on follow-up studies, the surgeons and the radiologists noticed that the left lobe of the liver started to grow, but the surgeons needed more assurance that there was enough volume in the left lobe of the liver. And as such, we did multiple, or rather follow-up CT volumetric studies in order to evaluate the volume of the left lobe of the liver and to see whether it was increasing in volume. And at a point of time where it had increased sufficiently, the surgeons were confident enough to perform a major liver resection. And this patient turned out to manage to have his liver mass removed, and he had a good outcome. Another thing that is up and coming, at least in National University Singapore, is augmented reality. By using visual overlays in real time, surgeons can use augmented reality or AR to assist in their approach. This is an example of a patient with MENS syndrome or multiple endocrinological neoplasia syndrome in a patient with recurrent paragangliomas. AR helps to localize the lesions for targeted excisions instead of an extensive pelvic sympathectomy. So really, the key takeaways is that abdominal radiology, especially MRI, has matured rapidly over the past few years. And I think in the near future, we can expect to see greater impact through prognostication and survival prediction. Radiomics and other quantitative methods that reflect disease biology will probably need more validation and simpler ways in order to implement into our clinical practice. Artificial intelligence will definitely translate into more opportunities for abdominal radiologists, but we also need to continue to seek innovation in other areas. As such, as radiologists, we should continue to contribute towards international best practices in abdominal imaging.